Now I request our beloved speakers to start the session.
Okay, so thank you very much, and we'll straight go on to the talks. And at the onset, I would like to thank Tablet India for organizing this wonderful meeting, Dr. Suchitra Pandit, my co-speaker, and also the AICC RCOG and the Indian College of Obstetricians and Gynecologists, our ICOG chairperson, Dr. Mandakini Megh, and secretary, Dr. Parag Biniwale, for giving us a CME points for this meeting. Today, I'm going to be speaking on controlled ovarian stimulation, basically for the general gynecologist. It is very important that most of the infertility workup and the treatment can happen at the general gynecologist level, and only the advanced infertility treatment or the difficult patients need to be referred to a specialized center. So a controlled ovarian stimulation is an integral part of intrauterine insemination. And I think every gynecologist should equip himself with the knowledge and the procedure for IUI. Doing IUI in a natural cycle doesn't give you as good effective results as an IUI stimulated cycle. And that is why it is very important that the first line of referral, the gynecologist should do a proper workup of this patient, and in fact should be able to treat them for IUI at a center. Now, what is the rationale for ovarian stimulation? It is to increase the number of oocytes that are ovulated, so you have an increased number of fertilizable oocytes, and that will increase your chances of conception. Now, when you look at the Cochrane database of 2016, it clearly says that there is an increase in the live birth rate in stimulated cycle as compared to a natural cycle IUI. And this is very simple to explain, is because of the number of oocytes which are released. And if you are monitoring the cycle well, it is without an increase in multiple pregnancy rates. And I will tell you exactly how you achieve those 2 to 4 follicles at the time of IUI, so that you offer your patient the best chance of success and also give them a very minimal risk of multiple pregnancies. Now, the goal of ovarian stimulation is to, in a non-ART cycle, which is an IUI cycle, we look at a monofollicular development, or at the most 2 to 3 follicles, especially in women who are over the age of 35. But in an ART cycle, we want to have multifollicular development. We need to get as many oocytes as possible, going up to a maximum of 15 to 18 oocytes, because that will allow us to give the patient a one-time stimulation, extract all the oocytes, and now with the process of vitrification, we are able to freeze the embryos and then transfer maybe 1 or 2 blastocysts. But whether it is an IUI stimulation or an IVF stimulation, it is very important to understand that there are specific protocols and very stringent monitoring, because a patient of IUI can also have hyperstimulation. In fact, in my clinic, we do not have any hyperstimulation in the ART treatment, because now we are transferring only 1 or maximum 2 blastocysts, but our maximum cases of hyperstimulation, although markedly reduced, now are still happening in the IUI cycles. So what are the drugs used in IUI? The gold standard or the benchmark now has been clomiphene citrate. Letrozole is now officially allowed to be used and in fact is the drug of choice in polycystic patients. Classification, investigation and management, excellent manual that has been released in 2018. We can use tamoxifen in patients who are resistant or not responsive to the oral ovulogens. You may want to combine with gonadotropins, and then it is the GnRH analogs, the use of antagonist or agonist. I'm not going to go into the details of pharmacokinetics, but nevertheless to say that clomiphene citrate is a selective estrogen receptor modulator, or SERM, has been used up to now as a drug of first choice in ovulation induction with IUI, since it is an orally administered drug and is cheaper than gonadotropin injections, and the doses between 50 to 100 milligrams can be given from day 2 to day 6. Now, how do you choose a candidate, whether it is day 2 or day 6? That depends upon what type of response are you wanting from that patient. If you start the drug on the second day because of its negative feedback mechanism, there is an early increase in the FSH, thereby causing an increased recruitment of follicles, thereby giving you a multifollicular development. On the contrary, if you start the clomiphene on day 5, day 6 of the cycle, by then the dominant follicle has been already predetermined by the body, and your negative feedback, which will increase your FSH, is not going to be able to recruit any more follicles, but will ensure that this one follicular grows, and most probably you will get a monofollicular development. So in younger patients, it is better to start it much later. In the older patients, more than 35, you may want to start it earlier in day 2 so that you have a little more number of follicles which are getting recruited. What about letrozole? It is an aromatase inhibitor. It suppresses the estrogen production, but does not have that anti-estrogenic effect of clomiphene in the late follicular phase. It's fewer side effects than clomiphene. Again, can be given 2.5 milligram from day 2 or day 6. But the main difference between letrozole and clomiphene is that letrozole, more often than not, will give you a monofollicular development. The anti-estrogenic activity of letrozole is short-lived, so you do not get poor endometrial linings that you may see in clomiphene citrate. The half-life of letrozole is much shorter than clomiphene, and letrozole can be given back-to-back cycles, whereas in clomiphene cycle, if you give it back-to-back cycles, you have an additive effect of the clomiphene and hence poor implantation rates in subsequent cycles. And hence clomiphene treatment is to be ideally given after a month gap in the patient in whom you would want to try the same treatment again. So you have the Cochrane database for comparison of letrozole and clomiphene, especially in the PCO group, which is the anovulatory or patients who have got irregular ovulations. You typically find that the letrozole has given you significantly better live birth rates as compared to clomiphene, with an odds ratio of 1.6, which means that letrozole is 1.6 times better live birth rates than clomiphene in patients in whom it has been used for ovulation induction, and there is no difference between them as far as rates of hyperstimulation or even rates of multiple pregnancy. So barring the increased pregnancy rates, the risk of hyperstimulation and the risk of multiple pregnancy remains the same in both the drugs. When you want to use gonadotropins, these are glycoprotein hormones that are generally extracted from the urine of menopausal women. The recombinant variants are produced in the laboratories. They stimulate growth by actively directing the ovarian FSH receptors, and it has no anti-estrogenic action on the cervical mucus, which can happen with clomiphene, or on the endometrium. So it gives you better follicular recruitment. It will give you better follicular growth and multifollicular development when you use gonadotrophins, either singularly or in combination with clomiphene or letrozole. So what is a comparison between low dose gonadotrophins versus clomiphene citrate, especially in a patient with PCOS? We have seen that chronic low dose stimulation will give you a better cycle as compared to clomiphene for IUI as respect to clinical pregnancy rates. So quite often we have seen that patients who are severe PCO do not respond to your clomiphene, whether it is 50 or 100 milligrams, given maybe even for 5 or 10 days. You often have to combine it or use gonadotrophin in a low dose so that you generate the follicle. At the same time, you do not have an increased recruitment of follicles, thereby preventing hyperstimulations. So what is the clinical experience of using antagonist? Now, when do you want to use antagonist in an IUI cycle? Typically, it is in a patient who has responded rather well, but when you give the HCG, there is no rupture. This is primarily sometimes because of premature LH surge. The LH has already surged before you have given the HCG injection. And in such patients, in the subsequent cycles, you may want to monitor the LH levels when the dominant follicle is 14 millimeters and then add the antagonist. Now that is important is because you allow the LH to remain low so that the follicle gets time to grow, and then you give the HCG, which will increase the LH, cause the LH surge, and allow this follicle to rupture. So in patients with premature LH surge, or in patients who are severely PCO, who have persistently very high LH levels, particularly the ones which come with no menses or menses which happens after 3 or 4 months, or those who regularly need to take withdrawal bleedings to get menses. These are the ones in whom the LH level, the endogenous LH level is extremely high, and such patients need to be either given 1 or 2 cycles of the birth control pill to get the LH level down so that you allow recruitment of follicles. Understand that in the beginning of the cycle, the LH and the FSH both have to be at a low level, which means that the gates are open for recruitment. If the LH is going to be persistently very high, you are not going to be able to recruit follicles, even if you persistently give them very high doses of gonadotrophins. And in such cases, we often give this patient 2 or 3 days of antagonist in the beginning of the cycle to get the LH levels down, and then you add the gonadotrophins or recombinant FSH to allow the recruitment and growth of these follicles. So antagonists can be used in 2 forms in IUI cycle. One where there is premature LH surge, typically where you measure the LH after the dominant follicle is 14 millimeters, or in persistently high LH patients where you want to maybe give them birth control pills in the first few cycles to get the LH levels down, or in the same treatment cycle, you can put them on the antagonist for 2 or 3 days initially before starting the stimulation. Also, a low dose antagonist particularly helps when you have a multi-follicular growth. Now, remember, once the estradiol level goes above a particular limit, the brain gets triggered as though there is a mature follicle. So the brain may not sometimes be able to differentiate between one mature follicle and 3 or 4 small follicles which are giving the same estrogen levels. And that's why you may want to give a small dose of the antagonist when there is multi-follicular growth, so that you can suppress the let's allow these follicles to grow before you give the stimulation. So this is a graphic picture of ovulation induction protocols. The top part tells you how you can use clomiphene or letrozole. Letrozole, particularly in the PCOS patients, you give the drug for 5 days and then you start monitoring the patient. If you find that there is recruitment and the dominant follicle is more than 13, 14, when you scan the patient after 5 days of CC or letrozole, there is frankly no need to add any more stimulatory drugs. You can monitor these follicles till the leading follicle goes up to 18 to 19 millimeters, and you can give the HCG trigger and then go ahead and either have planned relationships or you do a sperm wash. On the contrary, if you find that after 5 days of clomiphene or letrozole, your follicle recruitment has happened, but the follicles are all less than 12, 14 millimeters, then you may want to add a small dose of gonadotrophins, which you give every day, and you monitor the patient every 3 days till the leading follicle becomes 16 to 17. Thereafter, you monitor the patient every day to make sure that you give the trigger between the window of 18 to 20 millimeters. In PCO patients, you often find that there is no recruitment nor growth in the follicles after you have given CC or letrozole, particularly the severe PCO patients. And in those patients, you may want to add low chronic dose of gonadotrophins, and you continuously monitor the patient. In PCO and young patients, you have to be very careful of increasing the dose rapidly. And I suggest that you should not increase the dose at least for 7 days in PCO patients. And only after 7 days, if you find that the follicle growth is not happening or the endometrium is not developing, then double the dose and increase the dose. So what is the step up protocol? The step up protocol is a safer protocol, is a protocol that we should start treating patients with. It is a protocol where you give low dose of the gonadotrophins and subsequently increase it after 4 to 5 days in normal responders or even in patients whom you think are low responders. In PCO patients, you would not want to increase the dose for at least a week. I would be very careful and increase the dose only by 50% to make sure that I do not land up with severe hyperstimulation where I may have to cancel the cycle at the end. So it is safer to increase the dose by 50% than increase it by 100%, unless if the patient is an elderly patient or a poor responder or has previously shown poor response in earlier stimulatory cycles, and then you monitor these patients and you give the trigger only when the follicles are more than 18 to 20 millimeters. So what is the step down protocol? A step down protocol is meant for the people who are expert in monitoring and skills. This is a dose where you start with a high dose so as to increase the FSH in the early part of the cycle. This way you will be able to recruit a large number of follicles and then quickly go on to reduce the dose gradually so that only the best and the sturdiest follicles grow ahead and give you maybe 1 to 3 follicles at IUI. And this is a protocol which needs intense monitoring. This is a protocol where you have high chance of hyperstimulation, high chances of cancellation of the cycle. And hence, in my view, this is a protocol to be used only by ART centers if necessary in IUI. But for most of us, I think the step up protocol is something which is very good, which is in our control, and where we get equally good number of follicles and low risk of hyperstimulation. Now, what are the adjuvants that I would like to add in my cycles? In PCOS cycles, we would, if they have got insulin resistance or documented hyperinsulinemia, we would want to add metformin or even myoinositols, or even nowadays a combination of metformin and myoinositols. In our practice, if the patient has an increased BMI, is an obese patient, we give them metformin even if they don't demonstrate hyperinsulinemia, because it helps them to lose a bit of weight. In other non-PCO patients, the adjuvants are mainly to increase your implantation rates and clinical pregnancy rates. So in adjuvants in PCOS, you could have metformin, myoinositols, N-acetylcysteines. Patients with PCO particularly have very low levels of vitamin D, so you may want to add vitamin D. And PCO patients are the one where you need to give them the reduced form of folic acid, which is the active folic acid, or L-methylfolate. In other patients, you would want to give them antioxidants, vitamin E, micronutrients, low-dose aspirin in the elderly patients in the hope that it will increase the blood flows, and sildenafil in patients, vaginal use in patients with poor endometrial lining. Glucocorticoids, prednisolone, methylprednisolone, and dexamethasone has been used in the past in patients of PCO to reverse the circadian rhythm in them, thereby trying to get their cortisol levels low. But nowadays, not much advocated. Now, initially, I've been telling you all about monitoring patients. There are two arms how you can monitor patients. The first is the hormonal evaluation. Basic hormones of TSH, prolactin needs to be done in every infertile patient. But in advanced ART patients, we may want to do their E2, their LH, their progesterones in the start of the cycle, and even their E2, LH progesterones at the time of trigger, to decide whether we are going to do transfers or we are going to freeze all based on the progesterone levels. But by far and large in IUI cycles, hormonal evaluation in the treatment cycle is very rarely done, unless if the patient falls at the two extremes of treatment, very poor response, even no follicle coming up even after 10 to 12 days of injection, when you may want to do their E2 to see whether there is any endogenous estradiol happening. Or in the other group of hyperstimulation, where you see a large increased number of follicles, more than 4 dominant or growing follicles, where you may want to cancel the cycle, and so you may want to document their estradiol levels. So by far and large in IUI cycles, the monitoring is ultrasonographic, a transvaginal sonography, which needs to be done in a previous unstimulated cycle to make sure that there are no pathologies in the patient. And then when you want to monitor the patient for their follicular size, in the beginning of the treatment cycle, to rule out any ovarian cyst, to monitor endometrial thickness, timing of ovulation, and in certain scenarios, you may want to do their Doppler blood flows to check for their endometrial blood flow levels. Monitoring helps the physician basically to choose the right protocol if you want to decide to add to your CC or Letrozole gonadotrophins, or you want to do a pure gonadotrophin cycle because the CC and Letrozole perhaps is giving you luteinized unruptured follicles, or poor endometrial implantation, and getting the best possible outcome, avoiding hyperstimulation at any cost. So a baseline scan has to be done in every patient in an IUI, which most of us do not scan the patient. We put them on clomiphene, letrozole, and call them directly on day 8, which I think is not right. You need to scan the patient on the 2nd or 3rd day to make sure that there is no retention follicle from the previous cycle. There is no ovarian cyst, which is bigger than 10 or 12 millimeters in size. There is no presence of hydrosalpinx. This is a time that you can assess the ovarian reserve if you haven't checked the patient earlier on. This is a time, actually, in the baseline scan, you should rule out any abnormalities like a fibroid, adenomyosis, intrauterine adhesions, or even endometrial abnormalities. So a baseline scan done in the previous cycle will help you to plan out and to decide what is the stimulation protocol for your patient. In the treatment cycle, if the patient has a retention cyst, then such patients should be given a cycle of the birth control pill so that that cyst will go off in the next cycle. Or if you have facilities like an IVF center, you can do a transvaginal aspiration of the cyst and start the treatment cycle. So the cyst size should be ideally less than 12 to 14 millimeters. The endometrium should be less than 6 millimeters. If the endometrium is very thick, it indirectly will tell me that the progesterone levels in this patient is high, and maybe you would want to wait for a couple of days for the complete shedding of the endometrium to start their stimulatory cycles. Follicle tracking is done by having a beautiful chart that you can have at one glance all the relevant characteristics of the cycle, which includes the date and the day of the cycle, number of follicles that are growing in each ovary with their measurements, dynamics of the follicular growth can be charted, know how fast or how slow these follicles are growing over a period of 2 to 6 days, hormonal profile if it has been done in that cycle, and also what stimulatory agents you are adding for the patient. So a day-to-day scan to rule out any cyst, then you start the stimulation, and then you can possibly call the patient on day 8 or day 9, and then call them at regular intervals till the date of the trigger, and then you call them at the time of IUI to check for ovulation, and then put them on luteal phase supports. So what are the sonographic indicators of ovulation? A sudden collapse of the growing follicle, central echoes within the follicle, crenation of the follicular wall, decreased follicular size, appearance of the classic follicular fluid in the cul-de-sac, and formation of the corpus luteum, where the internal follicular area becomes isoecogenic with respect to the surrounding. At the same time, you're also doing endometrial tracking along with the follicle tracking, because this is a reliable bioassay of the patient's estrogen status. So I often tell my colleagues that if you do not see any follicle growing, check for the endometrial lining, and if you find that the endometrium is becoming triple line, is developing, we just have to have patience because there is endogenous estrogen and your follicle will now come up after a few days. So there is no need to panic or increase the doses. In the early proliferative phase, you will see a translucent and thin side on each midline echo. In the late proliferative phase, you will see an increase in the thickness with a hypoechoic area in the center. And following the ovulation, when the lining gets progestinized, you'll actually find that the lining gets compacted. So you'll find that the lining thickness may decrease by a few millimeters. It becomes dense echogenic on either side of the midline echo. So these are pictures to take you through the endometrium to show you how it looks in the beginning in the proliferative phase and then in the secretory or the progestinized state. So you need an optimum endometrial thickness is essential for conception. Ideally, we say between 8 to 12. Endometriums which are less than 6 millimeters are very poor areas for implantation. And endometriums which are very hypertrophic, 14, 18, 20, are also not suitable for implantations. A trilaminar endometrium, which is more than 8 millimeters, is considered favorable on the day of trigger of HCG. Hormonal monitoring, as I said, basically reserved for the difficult patients, for the elderly patients, for patients where you want to monitor their LH for premature LH search or for ART cycles. Basically in IUI, you would do it in hypo responders or in hyper responders. Ultrasonography is also important for us, as I said, to make sure that we are not dealing with somebody with a poor response, that is no follicular growth or at the most one follicle, and hyperstimulation where there are more than 4 growing follicles in the cycle, or even after the IUI is done, if the patient comes with severe pain, you have to rule out ovarian torsion by doing the Doppler flows in the ovarian vessels. And also if patient gets hyperstimulation, to measure the ovarian volume to check for the ascitic and pleural effusions. So what is the difference between a monofollicular and a multifollicular? Does the number of follicles have any influence on the pregnancy rates as far as IUI is concerned? Of course it does. A multifollicular is associated with a higher pregnancy rates. The chance of getting pregnant is increased with more than 3 follicles. It is 8% higher. At the same time, there is a trade-off. The risk of multiple pregnancies also increased by 6, 10, and 14% with 2, 3, or 4 follicles respectively. So an IUI patient has to be counseled for twin pregnancy because they have approximately a 6 to 10% chance when you have 2 to 3 follicles that are growing in that cycle. When do you cancel the cycles? If necessary, if there is hyper response, that is more than 4 growing follicles, I think it is important to counsel the patient, take the patient into confidence about the risk of not only OHSS, but more risk of multiple pregnancies, and then only go ahead maybe with a reduced HCG dose or adding cabergoline post IUI in these patients where the risk of hyperstimulation is reduced, but the risk of multiple pregnancy is not reduced. So if you have more than 4 follicles, the patient should be counseled and consented for risk of multiple pregnancies. And even one step further, that if they land with a triplet pregnancy or more, they should be willing for an embryo reduction. Cancellation of cycles, even if the lining is extremely thin or extremely thick, is a time that you need to cancel. So ladies and gentlemen, ovulation, induction, and IUI helps the physician to choose the most suitable protocol to get the best outcome, avoiding complications, basically OHSS and multiple pregnancies. It is important to have a baseline scan of this patient, ideally in the previous cycle, so that you can rule out polyps, fibroids, adenomyosis, hydrosalpinx, poor endometrial lining, and also look for their ovarian reserve, because all this will affect your chance of getting pregnant. Treatment cycle needs to be monitored from the 2nd to the 3rd day of the cycle. You choose your protocol depending on the age of the patient. number of years of infertility, and if she has any other comorbidities. We would ideally like to start with oral ovulagens for at least 2 to 3 cycles before you decide to give a combination with gonadotrophins or pure gonadotrophin cycles. Luteal support is essential in stimulated cycles, and it is important that you monitor these patients in every cycle and make sure that the patient is not taking oral ovulagens without your permission. Thank you very much for a patient hearing.
Thank you, sir. Thank you for this wonderful presentation on the ovulation induction. There are some questions already there. So would you like to answer it now?
We'll take the questions now. Let me start with the first question, which is asked by Swarankar. Is there any significance of letrozole regarding starting day like clomiphene? Yes, letrozole also can be given from day 2 to day 6, depending on what type of response you would want from that patient. If you give letrozole on day 2, you should expect a multifollicular response. The next question is by Aarti. What will be the trigger in case of an antagon cycle and dosage? In an antagon cycle, you have the option of using an agonist trigger, but then you must understand that there is immense luteal phase insufficiency, and you may have to add a high dose of progesterone in this patient. However, in an antagon cycle, you can also give an HCG trigger, which is also effective, and provided you are sure that this patient is not going to hyperstimulate. So if your antagon is given for premature ALH surge and there are only 1 or 2 follicles which have grown, you could give the trigger of HCG in this patient also. The third question is from Sangeeta. Sometimes follicle keeps growing till 10-12 millimeters. Then there is no increase in the size. How to treat? Yes, so this is a patient which I think may have had a premature ALH surge. And these are the patients where you would want to do their LH levels. And if the LH levels are more than 10, I think, Sangeeta, it is important to add gonadotrophins and antagonists to this patient, and they will respond very well. What is the next question is by Varsha. Hi, Varsha. This is a dose of antagonist in multifollicular growth. Also, what is the dose in high LH patients with antagonist given before stimulation? So the dose that I give of antagonist is the same. It's 0.25 subcutaneously. If I'm giving it before the start of the stimulation because of persistently high LH, I give it for at least 2 to 3 days so that the LH levels come down, and then I give them gonadotrophins, which is LH and FSH, for the next 4 days. And after that, I measure their LH again. And if the LH levels are rising again, I will add the antagon to the gonadotrophins. So it is called as a sandwich protocol. You give antagonist before stimulation, then you give stimulation, and then 4 to 5 days after stimulation, you add antagon to the stimulation again to ensure that the LH levels stay below and allow the follicle to grow. Sangeeta Kamra has asked a question. There are plenty of adjuvants available in the market. How to decide which one to give? Yes, it is a very difficult choice. You are actually spoiled for choice, but understand that these are all adjuvants, and adjuvants, like any antioxidants, are all the same. It is basically what you are used to writing, what you have confidence in is the one that you should be giving. Role of melatonin in ovulation induction. Frankly, melatonin does have a role. It is given in patients of poor responders, but I think it is more important to give DHEA to these patients rather than melatonin. I've often seen patients on melatonin getting sleep disturbances, and that's why it's not my personal choice to give patients melatonin. Sangeeta Kamra has again asked, metformin, whom to give myo, whom to give N-acetylcysteine or melatonin or chromium. So exactly. So in my practice, it is either metformin or combination of metformin with myo-inositols. Basically, I would give metformin and myo-inositol as a combination in the obese fertile patient. I would give metformin only if the patient has got hyperinsulinemia, which is documented, or where I need the patient to lose weight. I would add myo to patients in whom alone metformin is not really working very well, despite the patient being on diet and exercise. There's another question on, can you elaborate on the biochemical investigations? Actually, in an IUI cycle, I don't think we need to do too many investigations in everybody. Besides the infection screening that we would like to do in every patient, I like to do their CBC, their thyroid, which is only TSH, their prolactin, and maybe their sugars if they are on the obese side or they have PCO. The reason I do TSH is because quite often we find subclinical hypothyroidism, which is associated with subfertility. The next question is, how do you treat patients of retention follicle? As I said, if the follicle is more than 15-18 millimeters, I put them on 1 or 2 cycles of the birth control pill and call them in the subsequent cycles. What measures to be taken for down regulation prior to starting stimulation? Frankly, I do not like to down regulate patients of IUI. I would down regulate patients in IUI only if they have got persistently high LH levels, who come with very irregular periods, or patients who have always needed withdrawal treatment for getting their menses. Do you check for rupture? Yes, it is very important to document ovulation before you do the IUI. In our setup, if there is no documentary evidence of ovulation, I would repeat the dose of HCG and call the patient 24 hours later for the IUI. Yeah, so the next question by Latika is that quite often we have seen that the follicles are not ruptured, rather a cyst is formed. This is typical a case of either wrong timings of HCG, you waited for too long to give the HCG, maybe you waited till the follicle has gone to 20-24, or sometimes it is premature LH surge. And in such cases, I think in the subsequent cycle, you may want to measure their LH when the dominant follicle is more than 14. What is the role of adding estrogen when the endometrium is thin? Now, this is a thing that we have to understand that if you are scanning a patient in a natural cycle before the treatment cycle, and if the endometrium is thin in that cycle, I think you need to solve it in that cycle rather than treating the patient empirically and then having a thin lining. A thin lining in a treatment cycle can be only because of the effects of clomiphene citrate, in which case you may add estrogen. But if the lining is thin from before, then I think it is important to rule out why the lining is thin, maybe do a hysteroscopy and rule out any septum or septate uterus rather than starting the treatment straight away. The next question is how to tackle high LH in PCO. I think I've answered that question either by putting the patient on the birth control pills or on the antagon. If the patient fails to respond to HCG, I think I've answered that question. I think 3 things you have to rule out. One is wrong timing. Either you have given the HCG too early or too late. The second is premature LH surge, or it is the oral ovulogens give you persistent cyst formers. So you remove the CC or letrozole from your treatment protocol for this patient in the next cycle, and you put them on only gonadotrophin cycles. Dose of cabergoline to reduce the chance of OHSS is 0.25 to 0.5 depending on the weight of the patient, given for 4 to 7 days I start it generally on the day of HCG, or you can even start it on the day of IUI. Progestogen for as luteal support in IUI, yes, if it's a stimulated cycle, particularly with gonadotropins, I like to give luteal support. My drug of choice is dydrogesterone, dufestrone, in a dose of 20 milligrams in an IUI cycle. How do you differentiate between a luteinized unruptured follicle and a corpus luteum cyst? The corpus luteum cyst is crenated. It has got irregular borders, and you will see some amount of fluid in the pouch of Douglas. In a luteinized unruptured follicle, the follicle wall is very smooth and regular. If baseline shows functional cyst, I think you need to give the patient one dose of OC pills and call them the next cycle. Do you continue metformin once a pregnancy test is positive? Yes, although initially we gave metformin thinking it will reduce the risk of miscarriage in the first trimester. Now we know that when metformin is given in the first trimester, it gives you a better live birth rate, and that is the reason that I continue metformin till 12 weeks of gestation. If you decide to cancel the cycle, what drugs can we give the patient to prevent OHSs? The one drug that you should not give is HCG, because HCG is the trigger. HCG is the one which causes release of the mediator protein, which is VEGF2 alpha. So you do not give the HCG. You can either put the patient on the birth control pill or just put them on progestogens and leave them for them to get a withdrawal bleed. Role of synchronous follicle growth in IUI cycles. In IUI, you do not need as many follicles. So even if you manage to get 2 follicles, I think this is good enough. In IVF cycles, when you're trying to extract as many cycles, long downward regulation gives you excellent synchrony between the follicles, because all the follicles are down regulated and they respond very well. Why is trigger given earlier in IUI in stimulated cycles? Yes, the window is between 18 to 20, because as I said, you may have 2-3 follicles which are growing, and that will endogenously increase your ALH levels and cause rupture or premature LH surge. In a natural cycle, yes, you may want to wait till 22 millimeters to give the HCG level. When to start indomethacin tablet? It is to be started 2 days before. It is to be given for 2 days. You can also give them ibuprofen 600 milligrams on 2 days to prevent LH surge. And this is something that we don't do much in IUI, but we use it very effectively in the Shanghai protocol that I use for dual stimulation in poor responders or even in patients of oncofertility. How do you decide the dose? 5,000, 10,000? It is a personal choice. If you have a single follicle or at the most 2 follicles, you can get away by giving 5,000. If you have too many follicles, like 4 follicles, and the patient is insisting to go ahead, in such patient, I would again give 5,000. In rest of the patients, I think 10,000 should be the dose. Maximum dose of letrozole, 2.5 is the average, is the standard dose. We know some people have given up to 5 milligrams also of letrozole for 5 to 10 days. I don't think it works very well. Like an extended clomiphene regime, yes, you can try an extended letrozole regime where you can give the dose of 2.5 for a maximum of 10 days. In amenorrheic patient, can we start induction without withdrawal? You can, provided the patient has got hypoestrogen, Kishore. If the lining is extremely thick, then I think the patient needs to get a withdrawal bleed before you start their induction. But in some patients of hypoestrogen, if the lining is extremely thin, you can start the stimulation for these patients. What would be the line of stimulation in severe PCO patients already stimulated twice with letrozole only? Now it depends whether they have responded to letrozole or no. If they have responded to letrozole, I would do a third cycle of combination of letrozole and gonadotrophins. But if they have not responded at all to letrozole, then I would prefer to give them chronic low dose recombinant FSH. Could you please highlight the role of cabergoline? Cabergoline is a very effective drug to reduce your chance of hyperstimulation. It doesn't remove the possibility, but remarkably reduces the chance of hyperstimulation without affecting the risk of pregnancy. So it doesn't reduce your pregnancy chances, but it reduces the chances of because of its dopaminergic effect. The progesterone support is to be started on the day of IUI and continued for at least 15 days. What is high LH? Any LH that is more than 10 nanograms per ml is high, and such LH levels will not allow recruitment of follicles. In ovulation induction on day 12, if you have got reported hemorrhagic cyst, can we give a trigger? The hemorrhagic cyst could be a sign of corpus luteum, so maybe she's already ovulated. So check for, maybe you can do her LH and check for LH search, in which case then you do not have to give the trigger. You can ask the patients for planned relationships. In a lean PCO, what extra measures to be taken? I think you have to be extremely careful of hyperstimulation in these patients. So one thing in lean PCO patient is hyperstimulation. There's a question from Rachita Munjal. In sandwich protocol, you give antagonist for first 3 days, then you start the gonadotrophin from the next day for 4 days. On the 4th day, you measure the LH. If the LH is less than 10, you need not add the antagonist. But if the LH has started rising again, then you add antagonist to the gonadotrophins, and you continue both of them till the day of trigger. I hope I've made myself clear now. Dual trigger in IUI generally is not to be given. Dual trigger is given particularly in IVF cases where you find that you have had poor oocyte recovery, or you have had many immature oocytes. Only in those cases you would like to give a dual trigger. I routinely do not do dual trigger. When Parul's question is age more than 35 and FSH more than 9. More than 35 means what? Is she 40, 42 or she's 35, 36? And FSH, so I'm assuming your patient is 35 years old and on day 2 her FSH is 9. I think such patients will do very well. And if you have done her AMH also, and if the AMH is normal, then these patients you can get away by oral ovulations. If the AMH is low in this patient, then I think you should be quickly treating this patient with gonadotrophins and not doing any oral cycles with CC or letrozole. Deepak Shrestha is asking a question: how many minimum visits you can do if the patient cannot come frequently? I think a basal visit at day 2, the second visit at day 8, and the third visit for the trigger are the 3 main visits before the 4th visit for IUI. Basically, in most patients, there is a question about 1 or 2 IUIs. In most patients, we like to do only a single IUI. There is no study to suggest that 2 IUIs gives you a better result. There is a question that, do you ask patients to have intercourse in patients who are undergoing IUI? Yes, we tell them to have intercourse. We do not put any restrictions on their sexual activity. I think that is it. Most of the questions are repeat questions. So thank you very much. And I hand over to Dr. Suchitra Pandit.
Good afternoon, everybody. So I'm sure all of you all enjoyed that session on ovulation induction. So before we go on to the probiotics, I thought I'll quickly touch upon the very topical subject for today, the do's and don'ts for pregnant women. And this is, of course, not for the pregnant women per se, but it's for the obstetricians so that they can guide their patients. We are all gripped in the pandemic of COVID-19, and I'm sure amidst all the lockdowns, we are naturally worried because patients are worried and so are the doctors. And Foxy has come out with the GCPR. One, and even the second one is released recently. It's on the website. This is basically a scientific document which is made for all of us for facilitating management of a pregnant woman with suspected or confirmed COVID-19. So please do go through that. It's available on the website. Just to quickly take you through the fact file, the novel coronavirus, we all know that this is a new strain of the coronavirus which has caused COVID-19, was identified in Wuhan and China. And there are a number of the other coronaviruses infections which are also there and which have occurred in the past, the Middle Eastern Respiratory Syndrome and the SARS. But this one particularly, the COVID-19 strain, has a very high rate of transmission by droplet and through fomites, and that's how the exponential rise, there has been a sudden outburst of infections. And now what can we as doctors do? Basically, the healthcare persons, HCP means the healthcare persons like all of us, must educate their patients through phone calls, displays in the clinic, and encourage them to read from the internet, especially the Foxy FAQs, which are meant for our patients, and they can easily understand them because it's in very comprehensive language. Basically, the healthcare persons, as I said, that is us doctors, we have to educate the patients. And pregnant women at this time have to be assured of the best services. And if a woman needs to know about symptoms or about the course of infection of the recovery phase, they must be briefly explained. And of course, the government has time and again been talking about social distancing, the quarantine, and what is quarantine, what is isolation. Patients are always very, very confused. So I just want to quickly, briefly tell you, quarantine is a term which is used to separate and restrict movement of well persons who are known to be exposed, either directly or indirectly, or suspected to be exposed to a communicable disease, in case they become ill. And isolation means that they are separated and there is a restriction of ill. So I was discussing about this hand washing and I just mentioned about how it should be done. But people are very scared that, soap and water may not be ideal. But in fact, where hand sanitizers are not there, soap and waters are absolutely fine. And remember, the patients should be educated not to touch their face with hands, especially the nose, the eyes, because fomite transmission through the droplets is very common. Next, please. Next. A quick, can you go back, please? Can we go back?
Yes, ma'am.
So just again, something very important that patients should be told that the droplet infection is most important. So they must know what is the cough etiquette. So if somebody is having a runny nose, cough or a fever, and you don't have a handkerchief and you feel like sneezing, quickly into the elbow of your hand, you can cough it or sneeze it out. Because the droplets that are released can travel for several feet and they can actually touch a variety of objects like the bed rails, the doorknobs, wheelchairs, or any kind of equipment, even your stethoscopes and even the ultrasound Dopplers. So therefore be very, very careful about this. Next, please. So today the government is emphasizing on the cough etiquette, and they've quickly said that when you if you have a handkerchief or a mask, you cough into it. And if somebody else in front of you is coughing, just turn away, keep a hand on your face, or wear a mask if you have a coughing, coughing or a running nose. And most importantly today, nowhere spitting is allowed. So actually people are now told that they will be charged, they will have to pay, they're caught spitting in public places. Next please. A quick guide to the PPP. People are very worried, particularly patients are worried what kind of a mask they should wear. For patients, a simple double-layered cloth mask can be used, or even a 3-ply mask can be used. But people, doctors and the healthcare personnel who are working in a triage area or a general clinic, they should be wearing a disposable mask and latex gloves. In a fever clinic, more so, now today they are talking about patients where there are confirmed suspect or confirmed COVID-19 cases. That's where the N95 mask is of great value, and a face protection, that is a goggle and a shield. And a shield can actually be made even at home. It's a very easy procedure. It's just a plastic shield, and it's got to be made in a very simple manner, and that can be used, that can be reused, it can be washed with soap and water. And when somebody is performing deliveries, that's the time you actually need to use a full PPE kit. Now, if we know that it's a COVID positive patient, you're obviously going to wear a full PPE kit. But majority of the times you don't know, sometimes they may be asymptomatic and they are coming in. At that time, again, universal precautions are very, very helpful. Next, please. So this is a guideline which is given quickly as to, if you all can note this down, that which cases you need a triple layered mask, in which cases you need a N95 mask, where you need double gloves, and where you need the head cover and the shoe cover. Remember, it's only with the COVID positive patients that you're using your shoe covers, but in all the routine cases where they are asymptomatic patients, you're good enough. The healthcare personnel can use an N95. Today, many of the times, patients are wearing N95 mask, which is not actually required. And those of you who are frontline workers, and if you're wearing N95, remember, if you have 4 masks, you must have 4 brown paper envelopes. What you do is, the first day you use the N95 mask, you put it back in the, after the end of the day, put it in the envelope 1, allow it to air dry. The next day you use a new mask as number 2, and put it in the envelope label 2. And this way you have got 4 envelopes in which you can use 4 N95. And on the day 5, you can restart using the first mask. So each mask can be used for a minimum of 4 times, 4 or a maximum of 5. I see many people wearing the same mask for 8 days, 10 days until it gets completely soiled. That is of no use at all. Remember, it has to be dried, and air drying is a very, very good method. People who are frontline workers in the ICU, in the SARI ward, or who are involved in the CSSD on the laundry staff, those are the people again who have to particularly use a full PPE kit, because they come into the high risk and the moderate risk category of healthcare personnel. Next, please. So this is what the personal equipment looks like. Say you're operating, you have to don this complete suit, which is made of polypropylene. It's an impermeable surgical gown, which reaches right from the neck to the middle thigh. And then you have the gloves, and you have gloves you worn inside. And then again, you have the nitrile gloves, which you wear on the top. Again, you wear a goggle. If you're wearing spectacles, you don't really need goggles, but a hood cover is important. And you have an N95 mask already inside, and that's the time you also have a shoe cover. There is a waste collection bag where all these things can be disposed of and can be discarded. Next, please. Antenatal visits. I think all of you are faced with the problems as to how to call the patients and when to call the patients. Now, these are instructions which you can give to the patients. Also, there are changes in antenatal care. Minimize the number of the times that a pregnant woman has to go out of her house. However, a minimal level of care is necessary. Now, for a woman who does not have any high risk factors, you already know her from before, then a sonography is advised at 12 to 13 weeks, and then one at 18 to 22 weeks. But remember, the nuchal scan, the first trimester scan, may not always be possible. We normally recommend a nuchal scan with dual marker, but when it is not possible because of this lockdown, a quadruple marker can be done later on at 16 to 19 weeks. And each time the patient is coming for a sonography, the pregnancy visits can be timed with the sonographies. Now, unless the patient has a high risk factor, or say she has a small baby in the previous pregnancy, and this time you have to be more careful, you have to probably call those patients a little more frequently. But otherwise, in an uncomplicated pregnancy, the patient can be called between 28 to 30 weeks for the subsequent visit. And vaccinations and blood investigations can be planned during these visits. Now, in the last trimester, the growth scans are advised and performed only if indicated. Now, many of the clinics, the obstetricians are doing the sonographies themselves, but many a times there are also people from the fetal medicine department or the ultrasound department who are doing the scans. So that coordination is very, very important, because you don't want the pregnant lady to come again and again. Next, please. So as far as you are concerned, inform your patients well in time, so the waiting times can be calculated, and every patient visit is timed at half an hour. Don't crowd your OPD with patients. Next, please. Next slide. Next slide. Vaccines that are to be used in regular antenatal care. Again, tetanus toxoid or the Tdap vaccine should be taken as per schedule. The current flu vaccine will not provide protection against COVID-19, because it will provide protection only against swine flu. Currently, we do not have a vaccine to prevent COVID-19, and probably September to 2020 is a time when it may be coming into vogue. Advising patients to have good healthy food containing vitamin C, antioxidants, some amount of exercises, and rest is important. And of course, social distancing is important. Now, all these together can boost up the patient's immunity. Advise patients not to use any self-medications. If there is a problem, they can always call you up for a telemedicine consult. And remember, advise the patients to take all the recommended prenatal medicines as described. As far as patients are concerned, please give them the important telephone numbers, because they panic more if they're not able to contact you. And please tell your patients not to follow the WhatsApp rumors that keep coming in, particularly the one of the hand dryer. You know, you wash your hands, dry it with a hand dryer, or rinse your nose with salt water. I mean, those are things that are doing the WhatsApp route. So tell your patients not to believe that, and not to take any antibiotics without consulting yourself. Next, please. Now, sometimes, unfortunately, there is a family member who's having a COVID infection. Either it is confirmed or they are still in the phases of being confirmed. Now, in this situation, you have to advise them. They may have already been told by their physicians, but you have to tell them that isolation is very important. The infected person should be kept away in a separate room. But this pregnant lady, at this time, she can actually use a N95, FFP3 or an FFP2 mask, particularly when they are in the same room as the other people. Many times in joint families, there are other people to take care of the infected person. But in nuclear families, when there is a couple staying with their parents-in-law, in that time, probably the pregnant woman is caring for the infected person too. So she must take double protection for herself. Wash her hands with soap and water every time she goes into the room and out of the room. And as far as possible, the person who is isolated should eat in the room and not on the common dining table. And as far as possible, wear disposable gloves. Now, disposable gloves are not easily available everywhere. So in such a situation, make sure that the hand washing is very, very particular. And if somebody else can do the cleaning of the doorknobs, the phone, the bathroom, and the services in the infected person's room, that will play a big role. Next, please. Now, what I'd like all of you to tell your pregnant women is, tell them to be positive. Tell them to avoid the COVID news on the TV, because that can be very, very scary. Unnecessary travel should be avoided. And as far as a diet is concerned, it should be with plenty of fluids, fruits, nuts, vegetables, and if they're eating non-vegetarian food, it should be very well cooked. Small frequent meals and walking for about 5 to 10 minutes after every meal is important. Sometimes in places like Mumbai, the houses are small, but even there, practicing social distancing as much as possible is important. Now, there are many times when women may say that we are fine, our houses are fine, nobody else has got any infection, but there are buildings or houses in the locality where there may be problems. So therefore, the pregnant woman is always at a high risk of getting very sick from COVID-19. So therefore, protection is important. The 7-month ceremony, the baby showers, visiting of relatives should be completely discouraged. And pregnant women should avoid exposure to smoking, particularly if there are any home members smoking. They should stop, because now it is absolutely prohibited to smoke at home in this particular atmosphere. Transmission by mosquitoes has not yet been documented, and there is only one study which has shown fecal transmission, but it is better, always sensible, to practice sanitation hygiene. Many times these pregnant women have got older children in the house, so they could try and spend time with them, try to engage the children's mind as well as their own mind. And in nuclear families, sometimes the household chores will have to be done by them. But in a nuclear family, the husband should be encouraged, and you as a doctor can suggest to the patient's husband to also do that little bit of household share of work. Next, please. The national helpline numbers, I think everybody knows. I'm not going to go into details of this, but I'd like to mention that the GOI has got a very nice app called Arogya Setu app. It's a mobile app which is developed, which connects essential health services, and it gives all the information about risks, the current best practices, and the relevant advisories. So I think patients should be encouraged to download this from the Google Play Store and use it. It has got all the important helplines, and various states also have their own helplines. So all this is given in the Arogya Setu. Next, please. Next, please. Next, please. Can I have the next slide, please? Now, many times the questions that patients ask their doctors, should they take any pharmacoprophylaxis? Now, if there is a healthcare worker who is also pregnant, yes, she's advised to take the medication because she's working in the hospital area. And the recommended dose is 400 milligrams of hydroxychloroquine twice a day on day 1, and thereafter once weekly for 7 weeks. But this medicine should be taken provided there is no contraindication or a cardiac problem, G6PD deficiency or retinopathy, and it's always advisable to do an ECG and check the QT interval prior to taking the HCQs. But on a routine basis, pregnant women need not take any HCQ or any kind of a pharmacoprophylaxis. Also, asymptomatic healthcare workers who are not involved in caring for suspected or confirmed COVID cases, they too do not need to take. But if they are frontline workers or they are dealing with suspected or confirmed COVID cases, yes, in those situations, it is advisable to take HCQ after doing the baseline ECG. Next, please. Labor and delivery suites, of course, you know, those have been dealt with in many of the FOXY seminars, and I'm sure all the obstetricians have taken care. So you have to just assure your patients everything will be done as per protocol. Just because somebody has got a COVID infection doesn't mean it's a cesarean section. It just means that the labor is going to be monitored. But at the same time, cesarean section is reserved for obstetric indications. And we must remember one thing, don't prolong the second stage of labor. So just assure your patients about that. And as far as cord clamping is concerned, there's a lot of controversy. So currently we're saying just clamp the cord and hand over the baby to the neonatologist. Next, please. Even as far as surgical procedures are concerned, we must avoid giving Muhurat sections if it's indicated. But all the post-op procedure, the pre-op procedures and the surgical procedures remain the same. Only we must remember minimum number of personnel in the theatre, and the husbands who normally would like to come into the theatre in Mumbai and many of the metro cities, this is a practice. In the current situation, we are not recommending them to come inside the theatre. The post-operative care is usually as per standards, and only if it's a COVID positive patient or a suspected COVID patient do we talk about isolation. I'd like to mention over here that though the ICMR doesn't recommend doing a routine testing, COVID testing. There is a nasopharyngeal swab testing for pregnant women. The Brihan Mumbai Mahanagar Palika, that is of Maharashtra and of Mumbai, have clearly said that after 36 weeks, the woman and her companion who is going to be accompanying her to the hospital should have the COVID test, and if they are positive, they could be referred to the designated COVID hospitals, but if they are negative, they can be admitted in the hospitals where they are registered. Next, please. Next, please. Yeah, as far as breastfeeding is concerned, routinely we always advocate breastfeeding, and even the FOXY guidelines have clearly mentioned that the woman can continue to breastfeed her baby if she's asymptomatic and if she's suspected COVID, but she must remember to use a mask, use hand hygiene, and if the woman is a COVID positive patient, she should be counseled that there is a higher risk of her transmitting infection to the baby. So as far as she's COVID positive, she could still pump out the milk and give it in clean, sterile containers and with a dedicated breast milk pump, and the baby could be fed in by somebody else with the same EBM that is obtained. However, there are women who insist, despite having infection, they must be strictly told about using an N95 mask and clearly washing their hands 2 to 3 times before they feed the child. But otherwise, remember, we don't stop any women from breastfeeding, and the pregnant ladies, they have now delivered, the lactation consultants always advise them healthy food, practice social distancing, avoid any celebrations and gatherings for seeing the baby, and post-delivery maintain a good personal and hand hygiene. Those mothers who are COVID positives are always worried about the baby getting infected. Next, please. So there are some rules about testing of the neonates. Neonates who are born to mothers with COVID-19 infections can be tested within 14 days of delivery or up to 28 days. And symptomatic neonates are exposed to close contacts with COVID-19 infection. Some of the private hospitals have maintained social distancing between the mother and the child, the newborn. So in these cases, the mother should be counseled and at least should be shown the baby on the videos. And if the babies are symptomatic, then the specimens should be collected as soon as possible. Of course, there is a neonatologist or a pediatrician who will always guide you about this. And the sample collection also will be done by them. And it will depend upon whether the babies are mechanically ventilated or not. And this can be decided by the pediatricians at that particular time. Next, please. So basically what I'd like to tell all of you is when you're counseling your patients, just counsel them. Even if you're using a telemedicine, counsel them, tell them not to panic, that you're always there to help. And remember, you don't all the time have to use a PPE kit. You use it when you feel that, yes, there is asymptomatic patient who's got a high history of contact, or she's got somebody who's had infection in the house. In those cases, yes, you use all the universal precaution. But as far as your patients are concerned, tell them to stay home and stay safe. And I think we'll move on to the next presentation. So the next topic I'm going to be discussing is role of probiotics in vaginal infections, because this is something that we see in our day-to-day practice, recurrent vaginal infections. Next, please. We all know that our body has got microflora all throughout, starting from the scalp to the nose, to the oral cavity, to the skin, to the small bowel, large bowels, and perineum and the vagina. All these are living in symbiosis with each other. But for whatever reasons, if there is a drop in the immunity, then these same symbiotic relationships get affected. And that's where the infection starts. Next, please. So let's look at the vaginal flora. There are commensals, lactobacillus, which dominates the female urogenital tract. And these exist at almost 10 raised to 7 cells per ml in the vaginal fluid. Next, please. There are vaginal pathogens also. These are bacteria, fungi, and protozoa. Protozoa are the trichomonal species, fungi are the Candida albicans, and bacteria are the Gardnerella vaginalis, Mycoplasma hominis, bacteroids. And these commonly constitute and make the bacterial vaginosis. And then you have E. coli and Klebsiella, which cause UTI also. Next, please. So urogenital tract, naturally the infections coexist sometimes with the vaginal infections because of the close proximity. As all of you all know, we are all gynecologists and we have fair knowledge of the anatomy. The urethral opening, vagina and the anal canal are all in proximity. The perineal skin harbors all the PPMs which are derived from the fecal matter, and there's a constant transfer of the PPMs and the commensals into the vagina and the urethra. And therefore, we always advise patients, clean yourself well when you have gone to the toilet, whether you've gone to urinate or whether you've gone to defecate. And even remember, in the places where there's a lot of sweating, undergarments sometimes can get very sweaty. They can be friction from the skin and motility, particularly if you're driving or using a two-wheeler. In those cases also, the infections can be very, very common. Next, please. So what is the role of lactobacilli? In fact, very important role in maintaining the vaginal pH. In the presence of estrogen, there is an adequate glycogen stored in the vagina, and estrogen facilitates colonization of the lactobacillus in the vagina. The lactobacillus in turn acts on the glycogen stores and forms lactic acid, and this maintains the acidic environment, a pH of 4.5, particularly in the reproductive age group. Towards menopause, during pregnancy, or if the patients have prolonged periods of amenorrhea, then this pH is not maintained and the infection rates are much more higher. Next, please. So if we're looking at this particular diagram, it just explains whatever I've talked. In the presence of estrogen, the lactobacillus in the vagina act on the glycogen stores and produce the lactic acid. Next, please. So apart from maintaining the acidic environment, they also produce bacteriocins, some kind of a hydrogen peroxide. They also produce biosurfactants. These are substances which are produced by microorganisms which help them to adhere to the cell wall. Basically, this biosurfactant which is produced, it is a protein. This binds to the collagen of the body and hence it's called the collagen binding protein. Next, please. What then causes the altered vaginal flora? I already mentioned about menopause and during periods or in prolonged phases of amenorrhea during pregnancy. If there's an unhealthy urogenital hygiene, infected sexual partner, if there is a prolonged course of antibiotics, diabetes mellitus, use of spermicides, insertion of a urinary catheter, if tampons are kept for a longer period of time, all these can cause a urogenital infection. Next, please. And what then happens because there is an altered vaginal flora? Obviously, candidal infections, bacterial vaginosis, and these can be recurrent because the pH doesn't get changed, and urinary tract infections. In fact, all these keep going on, and the patient really gets fed up. Next, please. Overgrowth of the Gardnerella vaginalis, bacteroids or mycoplasma. All these then cause a loss of the protective lactobacillus, and as a result of which the pH completely changes and instead of acidic becomes much more alkaline. So therefore there is a criteria for diagnosis, the AMSIS criteria, and it's clearly mentioned that more than 3 of the 4 criteria are present, it is positive for bacterial vaginosis. So typically a homogeneous white vaginal discharge, sometimes a fishy odor, a pH which is more than 4.5, clue cells which can be seen on a saline wet mount or on a gram stain. 10% of potassium hydroxide liberates the fishy-like odor. Next, please. This is also the Nugent test, which is a widely practiced and a reliable test. If there's a very low score, it is fairly normal. If it's a higher score, it is strongly suggestive of bacterial vaginosis. There could also be presence of gram-positive rods in the vaginal discharge, which can give a lesser score, and there can be presence of gram-negative rods and absence of lactobacilli, and they can give a high vaginal score. Next, please. So have a look at this particular picture. This is the Nugent score, which clearly says that there's a lactobacilli Gardnerella vaginalis, and the scores are written on the side. So as far as lactobacilli is concerned, when there are 0 lactobacilli, the score is 4. Whereas as far as Gardnerella or bacteroids is concerned, if they are 0 in number, the score is 0, but if they are 30 and above, the score goes to 4. And as far as the gram-negative bacilli are concerned, if they are 0, the score is 0. If they are more than 30, the score goes up to 2. So you're going to count the total number of scores, because N is the number of scores for each bacterial morphotype, which is listed below. Next, please. So 0 to 3 is normal, 4 to 6 is intermediate, and 7 to 10 is bacterial vaginosis. Next, please. What about fungal vaginitis? Candida, as we all know, is the major cause of infection, and we've already discussed even patients who are on the birth control pill for a longer time may also have candidal infection. And this is one of the very, very common accompaniments of women with diabetes and those on broad spectrum antibiotics. Next, please. UTI, very, very common. The recurrence rate is almost 50%, because majority of the times the diagnosis occurs, a patient starts with antibiotics, feels better in 2 days, stops taking it. So the recurrence rates are very, very high. And recurrent UTI is also seen in women who've got a prior vaginal colonization with pathogenic bacteria from the intestine. And the common UTI pathogens are E. coli, Klebsiella, and Proteus. And what is the treatment? Obviously, drink plenty of water, send the urine for a urine routine and a culture, and start off with antibiotics. Sometimes the patients complain of burning, so you have to give something to reduce that burning sensation. Ask them to empty their bladder frequently, and hopefully the urine culture report arrives and the antibiotics that you've started are the same and the UTI gets treated. But ask the patients to always check the urine routine after 10 days. That is 7 days of the antibiotics stop. After 3 more days, collect the urine specimen, and it should be a midstream urine specimen, which will give a better report. Next, please. So, if you're looking at the urogenital infections, these are associated. Bacterial vaginosis associated with cervicitis, endometritis, PID, tubal infertility, chorioamnionitis, commonly cause PROMs and PPRMs in preterm labor. And the associated complications, the UTI, the urethral syndrome, and the uncorrected UTIs or the recurrent UTIs, which can lead to pyelonephritis. Next, please. Complications of the upper genital tract infection, cervicitis, we all know, endometriosis, PIDs, and all the 3 conditions can lead to infertility and ectopic pregnancy, and bacterial vaginosis can be a part and parcel of all this. Next, please. So the complications of upper genital tract infection, which we are worried about as far as obstetrics is concerned, is the chorioamnionitis, because infection of the placental membranes can lead to PPROM. Now the baby is above 26-27 weeks, it is salvageable, but if this leaking occurs much more earlier, then probably you've lost the baby. The patients may also have a much more higher incidence of preterm labor, and therefore it is worth treating the bacterial vaginosis. Next, please. So these are all the complications which can occur. Next, please. So restoration of the lactobacilli, which are dominantly seen as the commensal vaginal flora, is very, very important. And that's the challenge of restoring the LB. Next, please. So what do the probiotics do? One of the probiotics is Ecoflora. Basically, they contain Lactobacillus rhamnosus GR1 and Lactobacillus reuteri RC14. These are isolated from the distal vaginal and urethral regions of normal women. 2 strains survived. They passed through the GI tract and have been recovered even in the feces. And 2 strains have been recovered from the vagina within 1 week of starting the supplement. So extensive scientific document is available for the safety and the efficacy. Next, please. Because people tend to wonder, we are treating the bacterial vaginosis, but why is it coming back and forth? So that's where the role of the probiotics. They have a very unique mechanism of action. Secretion of lactic acid and restoring the acidic pH. secretion of bacteriocins, secretions of the biosurfactants, most importantly, breaking the biofilm barrier and modulating the inflammatory mediators and restoring the lactobacilli and hence the pH in the vagina. Next, please. So what's the importance of H2O2, that is a hydrogen peroxide, in treating vaginal infections? H2O2 is basically present in the vaginal secretions and exhibits a toxic effects against the pathogens. In vitro studies have documented that H2O2 producing lactobacilli are bactericidal, even to HIV, obviously to the Gardnerella vaginalis bacteroid species, the Neisseria gonorrhea, and even the Candida. And H2O2 generates cytotoxic reactive oxygen molecules, superoxide and hydroxyl radicals in the vaginal fluid, which kills the vaginal pathogens. Next, please. Studies reveal the importance of H2O2 in the upper genital tract and the IVF cases. Many times these studies have shown that if there is an absence of H2O2 producing lactobacilli, it leads to development of cervicitis, it leads to the PPRM and preterm labor, and even in IVF patients, it has been found that when there is a decreased vaginal concentration of H2O2 producing lactobacilli, the conception rates fall down and there's an increased rate of pregnancy loss. And this has been documented in the infectious disease of Gynecologists in 2003, way back at that time. Next, please. So only the lactobacilli species produce GR1 and RC14, and therefore it's very important that all these three act together and act on the biofilm. Next, please. Breaking the biofilm, very, very essential. Deconvolution microscopy has been used to examine the ability of the rhamnosus GR1 to penetrate the 3-day E. coli biofilm. And this is the picture which is showing it's about 5 layers thick and this biofilm has to be broken. Next, please. So as far as Ecoflora is concerned, when you're looking at other probiotics, how are they different from the general lactobacilli species? Well, Ecoflora is site-specific to vaginal microflora, produces hydrogen peroxide, produces biosurfactant, is in adherence to vaginal cells, and it breaks the biofilm. And many of the other probiotics may help, but not to the same extent that the Ecoflora helps. Next, please. Because basically it is a combination of the Lactobacillus rhamnosus. There are several randomized double-blind placebo-controlled studies of oral lactobacilli to improve the vaginal flora. Again, improved treatment of recurrent vulvovaginitis with fluconazole plus the probiotic which contains lactobacillus GR1 and RC14, and an improved cure of the, again, the same group. Next, please. Clinical studies of the RC14 and GR1. Many of these studies have been published, and clearly it has been said that if probiotics are put along with the antimicrobials, whether it's metronidazole, whether it's tinidazole, or whether it's the fluconazole, they have definitely shown a positive improvement, and this has been proven in some of the randomized double-blind placebo-controlled trials. Next, please. Again, this is a very interesting paper by Dr. Kamla Selvaraj and Priya Selvaraj published in the Journal of Obs and Gynae. Benefits of probiotic treatment in cases of bad obstetric history and prevention of post-IVF complications. Next, please. 70 pregnant women with bad obstetric history, they were treated with the probiotic Ecoflora and along with the infertility treatment, and they compared it with 70 control cases who were not treated with the probiotics and they had only the infertility treatment. Next, please. It was clearly shown that there is a benefit, there is a successful take-home baby rate, nearly 63%, and the fetal loss rate was, with the probiotics, the successful delivery rate was seen in 80% of the cases, and the fetal loss was only 20% as compared to 63% in the control group and 37% of fetal loss. So clearly it showed in that paper that the GR1 L rhamnosus and the Reuteri RC14 had played a definite role in cases of bad obstetric history. It prevents the ascending infection, improves the mucosal immunity, helps in better conception rate, and helps in a safe delivery. Next, please. So, what do these clinical trials eventually reveal? Oral supplementation of these two strains reduces the colonization of pathogens, restores the healthy vaginal flora, prevents the recurrence of bacterial vaginosis, vaginitis, as well as UTI, prevents the pregnancy complications, and probably helps to increase the success rates of IVF. Next, please. So, what is the superiority? The vaginal specific, patent strains with proven efficacy, extensively studied across India as well as the globe. They have a technological advantage. They have got ensuring stability of the strains. The production of all these bacteriocins, biosurfactants are all present in this particular probiotic. And it's trusted by it's been used for many years and ensures freedom from recurrence and relapse. Next, please. So this is the probiotic which is being used for all these various investigations. And the dosage is basically 1 to 2 capsules per day and can be used for a period of 30 to 60 days. And it's a first oral probiotic which restores the vaginal flora and helps in all the conditions which I have mentioned. Next, please. Thank you very much for a patient hearing. And if there are any questions, I think there are some questions.
Thank you very much, Doctor, for the wonderful talk on the role of probiotic in gynecological infections. Yeah. Before going to the question answer,
yeah,
I just want to.
Yeah. So shall I take the question?
Yes, Doctor. Before going to the question answer, I just want to share some information.
Yes.
First of all, thank you very much, Doctor, for your wonderful presentation on all the 3 topics. And also, I want to thank all the participants who has participated with this short notice. Today, we have almost 400 plus registrations, doctors, and that's a very big achievement for us. And at the same time, more than 380 doctors already logged in and they are live. So that's the wonderful happening today. So now it's a question answer session. As you know, there are different way of asking the questions. Already the participants started asking questions.
Yeah.
Now we can answer the questions.
Yeah, okay. There's a question from Khushbu Agarwal who said that my sister nurse is 6 months pregnant, working in OBG ward. Should I advise her to take HCQ prophylaxis? Well, if you're not going to be seeing COVID patients and if you are going to take all the necessary precautions, you're seeing normal patients, in that situation, she's not required to take HCQ prophylaxis. And if she's dealing with asymptomatic patients, when she's helping you to examine, she should wear the complete gown, she should wear a mask, she wears goggles or spectacles if she's using that, and hand gloves. Yeah, it's not required at all. And yeah. And in Tamil Nadu, all pregnant women with EDD within 5 days. Yes, it's Dr. Jankiram. It's very true. Even in Mumbai, we have been giving instructions to do the COVID test, not even 5 days before the EDD, after they've crossed 37 weeks. That is after they have become term. But the ICMR guidelines still do not mention that. However, now I think state-wise, some of the recommendations are going to change. Now, is there any role of taking flu vaccine during this COVID period for the benefit? Normally, we do give flu vaccine, and that should be given after the first trimester. But it does not prevent COVID. It is meant only for the swine flu. If you're saying it gives benefit to the mother or the baby, well, not particularly right now for the COVID, but it takes care of the swine flu. Now, is pap smear mandatory to before you're taking an HPV vaccine? It's always better to do a pap smear and to find out if there is any particular reason. If the pap smear is absolutely normal, if it is infected, treat that infection and give her the HPV vaccine. However, if there is some problem there, treat that pap smear, whatever it says, do a colposcopy if indicated. Because if she's already got the HPV vaccine, almost 60 to 70% will have the HPV vaccine, and that will show as a grade 1 abnormal pap smear. But most of them revert back to normal with your local treatment. But if there is something like a grade 2 or a grade 3, then in those cases, you need to do a colposcopy, take a biopsy, and find out what the problem is. But otherwise, doing a routine pap smear, actually, this is one good opportunity to do it before giving the HPV vaccine. Can Ecoflora be used at any gestation? Usually it can, but most of the times we prefer to use it earlier because you want to prevent the preterm labor and the PPRNs, particularly in women who got a bad obstetric history. But using it for 7 and 10 days doesn't help. It should be used for at least 30 to 60 days. Is the PPE kit necessary for abortion procedures? No, if you're doing a medicated abortion, you don't need a PPE kit. But if you're doing a surgical abortion, yes, then in that case you do need it. But please test the patient, do the COVID test prior to doing it. In this case, there will be a short GA, so your anesthetist will need to use a PPE kit. You and your assistant will need to use the PPE kit, because in GA, though they are giving injections by the IV method, in case an intubation is required, aerosol procedures should be minimized and the anesthetist should be prepared. Majority of the times, if you're doing a second trimester termination, in those cases, the patient is got to be admitted and then you have to follow all the universal precautions. So is it necessary to do a COVID PCR test prior to elective cesarean sections? In the Mumbai, they're recommending it right now. Even Tamil Nadu, one of the doctors has said they have advised to do the COVID PCR test. But the ICMR guidelines and FOXI guidelines still do not suggest doing a COVID PCR test for every asymptomatic woman. However, where there is a high risk, whether she's come in contact with some patient, or whether if she's had a history of any person in the family having had it, then she should do the COVID PCR test. In Mumbai, we are doing it for everybody. When should you start probiotic? This is a question from Dr. Amrendra. When should you start probiotic in cases of bad obstetric history? In fact, I think when the patient comes to you for pre-conception counseling and you're doing investigation, it's a good idea to do a per speculum examination and ask her if she's had a history of a previous vaginal infection, and treat that infection before she conceives. After 3 months, once again, I usually give it at 14 weeks. And then again, once more, I do it at about 20 to 24 weeks. Many a times, patients come back with recurrent vaginitis at about 33, 34 weeks. Please ensure that you've done your glucose challenge test and there is no impaired glucose tolerance, because many of these women, if they've missed that glucose challenge test, they may be having diabetes, gestational diabetes, and they can have vaginal infections. What is the role of probiotic in preventing PIH? Well, strictly, there is no role of preventing PIH per se, but it reduces the incidence of bacterial vaginosis, definitely. And how safe is Ecoflora in pregnancy? If patients have had a history of preterm labor, what would be the appropriate dose and duration of Ecoflora for the prevention of preterm labor? Usually, the recommended dose is 2 capsules 2 to 3 times a day for at least a period of 30 to 60 days, and ideal to start it after 20 weeks, then repeat it once more at about 28 weeks. For patients with chronic cervicitis, this question is from Deepak Shrestha. Patients with chronic cervicitis and those who have undergone LEAP, is there any role of Ecoflora? Certainly, in fact, these patients have had recurrent cervicitis. I'm sure if you've done the LEAP, you have the histopath report and you know what the exact report is. But yes, in these patients, it is recommended that one is they abstain from intercourse for at least 3 to 4 months before they start resuming. You can give them a course of Ecoflora. Shweta Singh, is Ecoflora safe in first trimester? Yes, if it's indicated, if there is a reason to give it, please, it can be given, if there is a reason to give it. Uma Devi Natrajan, is it necessary to test all mothers at term undergoing COVID-19 screening? In Mumbai, and right now we've got the information that in Tamil Nadu also they're testing all the women at term. So yes, we are doing the test, but as I mentioned before, the ICMR has not yet mentioned that. Redmi asks whether autoclaved cloth surgical gowns can be used instead of polypropylene. Well, the cloth surgical gown is not impermeable. So if there is an asymptomatic suspected or a suspected COVID positive patient or a COVID patient, it is safer to use a plastic gown underneath. You can wear the PPE kit, and over that, if you want, you can wear the surgical gown. But just a plain surgical gown is not recommended as a PPE. Redmi has also said, can we do COVID test in emergencies? No, unfortunately, you cannot in an emergency situation. So if your hospital is prepared to take emergency patients, like many hospitals in Mumbai do not take emergencies, but there are some designated hospitals which the bigger hospitals are taking emergencies. In those cases, there is no way they can do it. So they just use universal precautions, and they assume that the patient is COVID positive. And later on, they send the test, because remember, the test takes at least 48 hours for the report to come. And if there's any doubt, it is always referred to the standard reference lab. In Mumbai, it's Kasturba. And till the report comes, you have to inform the patient. She has to be in touch with you, and she has to actually be at home in isolation. Umadevi Natrajan has asked whether there is a good antifungal drug that be given to the antenatal mother. Well, we don't give oral fluconazole, but you can give vaginal test series which contain the antifungal. Many times it is safer to give a combination of an antifungal along with an anti-trichomonal, because and something like an Ecoflora, which will prevent the recurrence of the vaginal infection. Khushbu Agarwal is saying, wondering if probiotics can be directly inserted vaginally. No, right now the probiotics have to be taken orally, because the bacilli that they contain act best when they are taken orally. And is Ecoflora safest in pregnancy? Well, it's difficult to say whether it's safest, but it can be given. And as I said, in the first trimester, generally we like to avoid. If you're giving it as a prophylactic, please avoid it. If there is a requirement, yes, then give it. And okay, so if that's the end of the questions, I'll say thank you very much. And thanks to the viewers. Okay, the last question, Umadevi Natrajan, what is the material by which PPE should be made up of? It's polypropylene. It's actually a very fine plastic material which is impervious, and they define it by the GSM. So anything which is more than a 65 to 80 GSM is much more better for a PPE. It should be impermeable to the body fluids and to the blood and to whatever fluids that come on you. The last question, Kujit Kumar, does Ecoflora have a role in infertility? Yes, we just mentioned that it plays a role of probiotic, particularly in women who've got VOH, and it improves the conception rates, and it also reduces the infection. And that's where when you're doing the IUI or you're doing an IVF, again there the incidence of bacterial vaginosis is reduced, so the chance that a patient takes the baby to term are much more higher.
Thank you, Doctor. A very big thanks for the wonderful question and answer session. Thank you once again to Dr. Ameet and Dr. Suchitra Pandit for their time given to us for the deliberation of these three topics. And at the same time, I want to thank all the participants from India as well as Nepal. So thanks once again. And with your permission, now I just want to wind up this session.